and just give some information. So Dr. Adekweju is an experienced public health physician with over 15 years of experience in public health, program design, and management. She has worked for several years as a consultant to non-governmental, private, and public sector organizations in the areas of health system strengthening, focused on local lessons and solutions to the universal healthcare coverage. She is skilled in policy evaluation and analysis for health systems research and science to table knowledge translation for program implementation. She has served as a lead program specialist at Hospital Assist Nigeria, a public health consultancy firm that has served many state and national level clients in the health system strengthening and development sphere. She leads sexual and reproductive health services delivery at the Initiative for Equal Rights, and also is the founder and national co-chair of the Women in Global Health Nigeria, where she leads initiatives and advocacy for gender parity in global healthcare leadership in Nigeria. She believes that low to middle income countries in the global south have significant insights to add to the conversation on global health. And as such, she aligns her career in the direction of making these contributions palpable. We thank you, Dr. Peju, for joining us this evening. We would like to ask everyone to please mute their mics and turn off their cameras aside the panelists as Dr. Peju takes the floor. Dr. Peju, you're welcome. You can please share your screen.
Thank you very much. And I will try to the limits of my tech abilities, which I'm going to go into as we... All right, so I think, yeah. Right, so perfect. Can we see my screen?
Yes, we can.
Okay, perfect, all right. Thank you very much to the Healthcare Leadership Academy. I'm extremely excited to be here, and I'm extremely honored to be here. And I do see some panelists that I recognize, a friend and a comrade in the house, Dr. Benjamin.
Awesome.
And yeah, and I'm also excited about the fact that we have enough and a growing representation of male allies, not just in this panel, but also in the healthcare space. I'm a physician, clinical physician before I transmuted to public health, and I've also been a patient. And I am at any point in time a patient because I too do still access healthcare. So I can speak about the healthcare system from a 360 perspective, both as a giver and as a receiver of healthcare as a woman. And however, I will first lead into, before we speak about the narrow healthcare delivery system and how that relates to gender, I want to think about a brief presentation. I do like to speak off the cuff, but I will do a brief presentation just to guide me. And then after that, we can speak off the cuff about looking at gender from the entire health system space, and then it can give an insight and also solutions to how we got here. How is the gender space rather biased? And I invite you to agree and disagree with me, and then we can discuss this. So without much ado, we'll go straight into it. Bombshell ahead, yes. And my first bombshell is that health systems are disfavorably biased to the genders that are not male-centric. And I started with that because I invite discourse, I invite disagreements, and I invite agreements. But as we go along, I think we can lead ourselves through the methodology in which we can state this as a fact. So I like to apply my methodology for looking at gender bias, starting from the WHO definition of health system building blocks. And I think it's a very good place to start. And using that, the health system framework essentially looks at all the blocks that need to work together on the left to give the overall outcomes and goals that we're looking at on the right. So the outcome and goals that we're looking at is improved health, and equity in that health. We want a health system that is responsive. We want social and financial risk protection so that while you're seeking health, your finances are protected and your social status is protected. In a low to middle income country, oftentimes we can lose all our finances when we seek health. Everyone says that everybody is just one accident away or one health incident away from bankruptcy. And it can't be the truth, because we have seen people who we even consider middle class, and then you have one single self or dependent chronic illness, and that can essentially wipe out all your savings or your financial protection. We also want an improved efficiency in the health system. Now, these are all the goals or outcomes that we want to target if we're looking for good health, individual and population-based. And the WHO systems framework has been able to cut down into building blocks all the frames that need to come together in order to achieve this. So the system building blocks, we think about service delivery, has to be efficient. The health workforce has to be efficient. Health information has to be efficient. Medical products, vaccines, and technologies have to be efficient. Financing has to be efficient. Leadership and governance also has to be efficient. And then my presentation today gets to say that one of the issues we're having with the overall goals and outcomes is that none of these frameworks are efficient in Nigeria, and none of them are efficient because one aspect that is missing is they don't have a properly integrated gender lens. And what I mean by that is service delivery has a gender bias. The health workforce has a gender bias. Health information has a gender bias. Medical products, vaccines, and technologies has a gender bias. Healthcare financing has a gender bias. And of course, leadership and governance in the healthcare space has a gender bias. So if we look at all of that, that is the reason why we have on the right, we're unable to achieve on the right overall goals and outcomes. There are other reasons, of course, but from this point of view, in this discussion, we want to look at how lacking gender focus, we've been unable to get them right. So again, I like to speak of the cuff. The relevance of this approach is it allows you to break down the health system into its blocks and then attack it in that. And I think it's a very neat methodology. The reason why we cone this down to methodology is once we get the problem on a building blocks basis, then we can apply solutions on that building blocks basis. So again, we say service delivery, good service delivery comprises quality, access, safety, and coverage. The healthcare workforce, a well-performing healthcare workforce, consists of human resources management skills and policies. And so we have to, so this is also the minimum that we need to get right. Health information system is a well-performing system that ensures the production, analysis, dissemination, and use of timely and reliable information. If we have a pandemic, for instance, like we all globally experience, but also, of course, nationally experience, where are we collecting the data from? Where are the hotspots of infection? What do we then allude to the hotspots of infection, collecting data in real time and using it to make decisions? How well do we apply a gender lens to that? Medical products, procurement and supply programs need to ensure equitable access, assured quality, and cost-effective use. I will speak on this when I speak about the role of the woman, not just as a patient, but as the domestic caregiver. And because it's essential to know that if the woman, an individual woman in the healthcare space has two roles. First of all, she assesses it as herself, as an individual seeking healthcare. And then she also assesses it as basically being the domestic handholder or the interface of the health system in the home. The person that carries out all the national health programs, be it if you want to do malaria programming, if you want to do water and sanitation programming, if you even want to do vaccination, if you want to do under 5 immunization, if you want to do diarrhea control, the person that is delivering that healthcare at the level of the home, which is really, when we say public health, we mean public health at the level of people's homes, is the woman. The community health care workers or the health extension workers, their partner in the domestic situation is the woman. So if you don't have a woman with a correct health-seeking behavior who integrates properly with the public health, then you will not have that service delivery being implemented. Financing, of course, the big question when it comes to universal healthcare is that you must be able to have access healthcare and not lose your financial status. And the answer to this, obviously, to get to universal healthcare is health insurance. And that it gives you protection from financial disaster based on a health event. Now, health insurance, how gender free is it? How easy does the woman exercise autonomy over her own finances and not as a wife or as a codependent? How many women are able to operate their own finances? Remembering again, she's operating on two levels, one as her individual and one as the caregiver. And yet, this woman, is she able to make autonomous decisions over the family finances? Is she able to say, I'm going to go and buy health insurance for the whole family today? Are there instruments for which this woman can access money to get financial protection? And those are things that we can discuss as we go along. And then, of course, the final one, which again has kind of like an umbrella effect, is with leadership and governance. The reason why we are still experiencing the gender bias in service delivery, healthcare workforce, health information, medical products, and financing is that not enough women are in the governance room. Not enough women are in the space where decisions and implementation designs, policy designs and policy implementations are being made. And therefore, many of those policies are gender blind. So we design policies and say, even when it comes to water and sanitation, for instance, something as basic as that. In other lower to middle income countries, you put one toilet and you say, oh, we have a wash situation. So we create a public toilet in a place and say, oh, we've given a public toilet to this community. And then we know that, of course, if you're thinking about sanitation and using the toilet, there is no time limit to it. So if we design a toilet and put it in a place where, and give it to a community, have we thought about the fact that is it easily accessible to everyone? If a man gets up at 2 a.m. to use that toilet that you have provided, is it free from sexual violence or any form of sexual attack? But is a woman likely to be able to get up and use that toilet? Because the person that designs that doesn't realize that the issue of safety or gender-based violence is intersecting with the issue of sanitation. It doesn't occur to them, you know? So when we think about last mile healthcare delivery, having to put women healthcare workers who in Nigeria make about over 85% of the healthcare delivery workers are female. We want to give last mile healthcare delivery. We want to get to the last place. This is not to say that we shouldn't subject women to physical danger. It's not even about the physical built environment, but it's even about the other social environments. How are we prepared to protect the women which we're sending on last mile healthcare delivery implementation journeys? How well are we protecting them from sexual violence? A lot of that is underreported. So most of the time, the women don't feel safe to go. So, and this, again, we can go into granular examples. I'll just rush through this presentation and then we can speak off the cuff. But just to set the stage for all these building blocks and how we design policy and how we implement policy must always have a woman in the room, because she can then bring her unique perspective and tell you how you're not really thinking of what this means for the other gender when you're implementing like this. So can we truly demonstrate the gender balance in the healthcare system? And I said, my position is yes, and then we can approach this by interrogating the gender component within the building blocks approach, which I've already done, but I'll give a couple of examples. So each example on the left has, each building block on the left has an example question on the right. Just an example question, is by no means exhaustive. So for instance, if we say service delivery, how well designed is the service delivery for the health needs of a woman? We talk about privacy, we talk about timing, we talk about autonomy, and we talk about respect of women's wishes. We say we deliver, for instance, antenatal care, and we are very big on targeting maternal and child health. And, you know, but we go to, at the level of service delivery, I've been in both especially in the public system, I can speak for that. You go into a room to do your antenatal care, you have this big room and maybe 2 or 3 screened beds in the corner, right? And then the healthcare workers, the doctors, very often male, will have the different patients walk in and think it's all right for a pregnant woman to just, so 3 different corners and 3 different beds, just undress and lie down on the bed. And nobody is thinking of what is the autonomy or the privacy of somebody who's especially vulnerable and, feeling like already I am undressing in front of somebody who because I want to access healthcare and being told to undress. And, maybe they can deal with that because oftentimes a little pushback, oh, you're not ready. If you know you weren't going to take off your clothes, you're not ready. But then this is not about, at any point in time in those examining rooms, there can be up to 16 people in the room coming in and going out. And you say, oh, there's a screen for privacy. So you have to ask yourself, is someone especially thinking of the gender of that person, who is the gender of the patient, the autonomy of the patient, the comfort of the patient, knowing also that this is a society that has actually deliberately sexualized female nudity. So it's a catch-22. When it comes to healthcare workforce, you can ask how many women are in the healthcare workforce. I can give you a good answer to that, about 80%, but the question is at what level? At the lower level, you can find quite a number of women, community health extension workers, community healthcare workers, nurses. But as you see, as you go up the cadre, the gender begins to change. The women begin to drop off. How many, what's the percentage of male physicians to female physicians? Who then, if we had more female physicians, maybe they would have been able to influence the ANC space, for instance, for the example that I gave. But when you have the people that are delivering it, not the gender for whom those issues affect, you can see why there's very little change or progress in the direction that we need it to go. How easy is it to get to the peak of the healthcare workforce as a woman? When you take your life course, maybe you take a couple of years stacked together or interrupted to have your child, how easy is it for you to come back? How easy is it for you to do your exclusive 6 months? And I say one of the funniest jokes ever is how even within the healthcare space that is saying a woman should breastfeed for about 2 years or 6 months at the minimum, there is no design. In Nigeria now, not enough states give 6 months maternity leave. We don't have national coverage of 6 months maternity leave, but that is there in the policy that we must breastfeed for 6 months. So the hard choice a lot of women have to make is to take that time off work completely. Lose your job, have a child for 2 years, find another one. And then when you get pregnant again, maybe the cycle continues, or babies are not being breastfed. So when we talk about breastfeeding, for instance, you might think it's a female issue, but breastfeeding. Oh, okay. So I think.
Okay, I want to tell, and I saw it down here.
Okay. Right. But breastfeeding is an issue related to child mortality. So breastfeeding is a national issue, is a national health issue. And yet people will look at it from a gender point of view. It's just women that want to breastfeed their children. But we know what breastfeeding outcomes are related to, about national immunity, So again, granular examples, I can't help it. Information, how well designed is health information and data to ensure that it meets women where they currently are? In Nigeria, we know that we don't prioritize girl education. So I don't speak as somebody from an urban area because I speak English and many of the people I know speak English. But we know that in Nigeria, we don't necessarily send women to school. So when we give health information and then we give it, 1, in English, and 2, we give it in written language. Because our response to people who did not go to school is, oh, this person does not speak or read English. Let us write it in Yoruba, forgetting that even Yoruba written language has to be learned. So it doesn't solve the problem just because we translate it to Yoruba or Hausa, or you can't read it, you can't read. Literacy is the ability to read. So if you translate it to Hausa, that person still cannot read Hausa just because they speak Hausa. They have to go to school for that. Medical products, how well distributed in the supply chain are medical products, medication, and consumables to reach women as patients and caregivers? Financing, I've already been over this. What's the access of women to autonomous health insurance to finance their health needs? And finally, again, I've been over it. What percentage of leadership and governance roles in the healthcare system are occupied by women? Now, the relevance of this approach, oh no, I think I've done this. Okay. So I'm going to give a few effects. What are the effects? Because otherwise, this is just me passionate in my house about these things, but these things have real effects. What are the effects? Maternal mortality of Nigeria is 814 per 100,000 live births. It's one of the worst in the world. The lifetime risk of a Nigerian woman dying during pregnancy, childbirth, postpartum, or post-abortion is 1 in 22. In contrast to the lifetime risk of developed countries, estimated as 1 in 4,900. And then another fact is, even though women constitute over 60% of the healthcare workforce, majority of them are overrepresented in the informal roles, the low status roles, the low paid care roles, and they are underrepresented in the professional or leadership positions. About less than 11% of the principal health decision-making bodies are led by women in Nigeria. And about 10% of our medical institutions of training are female-led. So far, there's been only one female health minister of a country that has one of the worst maternal mortality rates in the world. And we keep putting in the wrong gender alone, which is not to say, and then more facts, there are more, but let's put a few. Gender gap experienced by women in global health leadership has been well documented. And this includes gender bias and discrimination. Even female patients will say, I want to see a male doctor because they think the male doctor knows what he's saying more than you are. Again, that, oh, women are emotional, she may not be able to handle. Within the clinical space, there are some residencies that they will tell you they prefer a man. You know, only a man could handle 5 hours of surgery. From a gender that never gave birth, 24 hours of labor. They don't know what that feels like. But, you know, somehow a woman can stand up and operate. Unequal pay, sexual harassment, and work-life balances, because, you know, the woman has to do all of this, oftentimes with babies that are hip. And if you happen to be married to a spouse who's not necessarily a gender affirming, God help you. There are funding disparities, lack of mentorship opportunities, and safety concerns. Female workers in Nigeria, bringing it home, they're confronted with challenges and barriers associated with gender disparities, just like their counterparts in other parts of the world, especially in the healthcare sector. How much better could things be? Because, you know, I've talked about how bad it is, but, you know, you looking at it structurally, how much better could things be? So I just brought this out, and this is really from McKinsey, and it was doing kind of like a financial analysis on a healthcare marketing space, but I'll bring it home as we speak. Conducted by McKinsey, the IMF and other organizations has shown a positive effect between more women and diversity in leadership for companies and better financial performance. It speaks for itself. More women in the space. It's not because the men are doing a terrible job, but when you're focusing on the men, you're using just about 50% of your talent pool. If you have 100% and you're using only 50% of your potential arsenal at the problem over and over again, I mean, it doesn't do the system right if you can't apply the other half. Let's see what, you know, throw something else at it. How this relates to healthcare. Market of healthcare consumption is dominated by women. Remember, like I said, the woman is the caregiver. She is the domestic implementer of any national policy, any national health policy, be it HIV, be it malaria. If you were doing malaria and you're giving insecticide-treated nets, it's someone that has to put that net up in the night. And it's not the men. If you need to immunize and make sure all the children have all their immunization, someone is taking those children there. And you know, it's not the men. So if you want to keep Nigeria back, even in the COVID vaccination for adult vaccinations, the health seeking behavior, the men were there. I was at some of those when we were doing monitoring. And some of them were grumbling, I'm here because my wife won't leave me alone. So after she takes her vaccination, she's the one that's going to harass the other adults that, listen, you have to go and take your vaccination. Because already we know from research that health-seeking behavior in women is far higher than men. Men are immortal, let's not forget. Nothing gets to them, you know? So, I mean, quick joke, but you know that the social conditioning of men makes them less likely to seek healthcare than women. So you have an effective partner who you're not empowering enough. Increasing women's participation and removing bias in global and public health is not only critical, it's a necessary step towards improving women's health globally. And it is feasible, it's quite possible. And how can we break the bias? To that question. So I've broken it in a few steps, but I don't want to take too much of the time, and hope that as we, again, as we discuss, we can speak more. We need institutional drive and change within the healthcare sector. Gender participation to determine outcomes. So there's a need for public and private organizations to consider strategic investments towards building leadership training grants and scholarship to enable women attain vital leadership skills needed in building high-performance teams, negotiation, change management, and leadership through crisis. And this, for me, was one of the reasons why the Healthcare Leadership Academy was a no-brainer to be here, because there has to be that strategic drive, focusing on that leadership for women. And it's not nepotism. We're actually just trying to bridge a gap that was already there. Second, the deliberate mentorship from female leaders in the local, global, whatever, the level of global health professionals, creating opportunities for networking and increasing women's visibility. Let's get the women through the door. Everyone brings another 10 in, and we do that until we have some kind of parity. And then we need institutional change and implementation of effective policies to address issues such as discrimination. For instance, we want to look at, in the clinical space, why, when you say you have more surgeons than, more male surgeons than female surgeons, are we interrogating, is it actually true that less women are applying? Or is it that the women don't go through? Or if less women are applying, how does that institution create itself to look very unfriendly to women to stop them from applying? Instead of where we sit, which is women don't apply because they're not interested. It's not true. Sexual harassment, what are our responses towards sexual harassment? If you have sexual harassment while trying to deliver your work, whether you're a high-level healthcare worker or you're a last mile or community healthcare worker, you're serving the migrant, how do we teach the system that this is unacceptable? Gender-based violence, academic promotion, maternity leave, protecting a woman's maternity leave. Because oftentimes it feels as if a woman has to make a choice between having a child and having a career. It's not an easy choice, but we set it up that she has to make that choice. And I think I didn't go further than that because I really wanted to, invite more questions. And again, to reiterate, I put here again my earlier questions. So I led with a question. This entire presentation is not giving you the solutions inside the presentation, but I hope that as we discuss, we will find our way there. Again, I like to speak off the cuff, and I did a presentation. Thank you for listening, and I'm really grateful to have been able to do this. Thank you.
Thank you, Dr. Kweju. I kind of feel like this presentation deserves like a round of applause. It's an innovation. Thank you so much for that. It was rounded, it was thought-provoking, it was eye-opening, and I even dare say it was funny because there were little jokes here and there, some bombs you were throwing at our male allies. But I love
our allies. I love our allies. Not too much, but I love them.
Thank you, and we're all working together. So, and I think what's even very striking is the elements of this conversation that are often overlooked in the health space. I like the fact that you highlighted, why it's very important to actually see the role of the woman as the effective partner for whatever national healthcare agendas you're trying to pursue or coordinate. And that's very important. We know that even though most medical providers or healthcare workers are not generally or just, intending to provide better treatment to some people at the expense of others, more often than not, unexamined bias can create, harm. So it's actually very important to cast a glaring, bright spotlight on this bias. And so far, I like to think that many of our members of our audience have started to take some thoughts away from this. I think this is just a perfect segue for our next speaker. But at this point, I would like to just reiterate that our webinars are also opportunities to get answers to your questions. So I encourage everyone who is listening to please locate the chat box and drop your questions. We'll take them in the order in which you receive them. For our next presentation, it's also my pleasure to welcome Dr. Alex Nadozie. I'll just briefly share some insight about him and his work. He's a qualified medical doctor and seasoned health education promoter with over 10 years of practicing. He's a graduate of the Enugu State University of Science and Technology, Nigeria. He's a principal medical officer, Department of Surgery. If we remember clearly, Dr. Kweju threw some bombs at the surgery department. So I'm hopeful that Dr. Alex would be ready to, to speak to a bit of this at the Gwarinpa General Hospital, Abuja. And he's also the host of the online platform, The African ER. It's a program designed for experience sharing and networking of healthcare professionals across Africa. In the last 5 years, he has been on the remarkable mission of creating locally adapted health content that highlights and addresses the harmful health practices peculiar to Africans, as seen almost on a daily basis in the emergency departments of our hospitals. He believes that heavy disease burden affects a nation's development and delivery of care must be proactive in bridging these gaps. On the show, guests who are experts in diverse medical fields present these conditions in simple layman terms and even in local languages for the understanding of a wide African audience, with the aim of debunking myths that influence health-seeking behaviors, which ultimately impacts women's health outcomes, maternal mortality, and other prevalent health conditions. With over a dozen episodes recorded and disseminated via both traditional and digital media, with particular attention to women in the rural communities, the African ER's multidimensional impact is fast gaining ground, and we celebrate this. In 2021, he was a panelist alongside other African healthcare professionals at the October 2021 Africa Health Conference, where he contributed insights on competing priorities to quality improvement in the African health sector. He's currently undergoing a master's in public health from the University of South Wales, UK. Dr. Alex is community service driven and demonstrates this commitment to improving general health and safety outcomes by delivering voluntary first aid training for secondary schools and basketball clubs, as well as training for federal road safety patrol officers. Dr. Alex, it's a pleasure to have you join us this evening. The floor is yours. You're welcome to share your presentation.
Thank you very much. It is my pleasure to be here and to be able to share with you. I enjoyed Dr. Kweju's presentation. It was awesome. And even the jibes thrown at us is well accepted because I have some jibes to throw at my own gender as well.
Okay.
Because, yeah, this is about women, and then there's been this bias that we need to deal with, you know. So if you can see my slide.
Yes, we can. We can see it, sir. Go ahead.
Yeah. So is it still there?
Yes, we can see your slide. You can please go ahead.
Okay. So I want to come from a particular angle because, yeah, this is what we do. I practice in a general hospital, so hands-on in what we see. And general hospitals handle a lot of the poor and the middle class. So, and then Dr. Kweju talked about education. So we normally have this vicious cycle of poverty, ignorance, and disease. So we have a lot of all these issues. And this is what informs our creating the African emergency room, so that we can be able to talk to the people through our platforms to help them prevent those things that bring them to the hospital. Because how else will they know that they shouldn't practice one or two things that harm them? So today I just want to come from a particular angle to use it to feed what we are discussing here. Concerns from the labor ward particularly, what we have seen over the years in the labor ward of most of our hospitals, how the women have been handled, how they've been allowed to face their issues alone by husbands, you know, and family members. So I want to talk about, Dr. Kweju also talked about a little bit about maternal mortality and gave us a figure of 814 in our society. In some parts of our society in the northern part of the country, like in Zamfara State, it can get as high as over 1,000 women, 100,000 live births. So it is really high, and I want to talk about the first delay of the models that were given by Thaddeus and Main in 1994, the models, the three delays of maternal mortality. So, but first of all, let me make this preamble. Nigerians and Africans, indeed, we love marriages. Go to the southwest, you see how they celebrate weddings. Go to the southeast, go to the north, not central, every part of the country, see how we celebrate our wedding ceremonies and marriages. We love marriages. And if you think we love marriages, then see what we do with pregnancy and childbirth. You get married today, from tomorrow they are looking at the tummy of the woman to see if it has started protruding, to see if there's a baby, inside. So people are expecting, in 9 months, they want to hear the cry of the baby. So we love marriages, we love pregnancies and delivery. We love children in this part of the world. But unfortunately, how do we protect something we love so much? What are we doing about protecting women that go into childbearing so that they are alive to take care of the children and don't even die during having the fourth child or the fifth child or the sixth child and then leaving all the previous ones behind for nobody to adequately care for? So that is why I want to come from this angle. It is so unfortunate that we're not doing enough about protecting mothers, and that's why we have such a high figure of maternal mortality. So in 1994, like I said, Thaddeus and Main described this model of maternal mortality with 3 delays. The first one is delay in deciding to seek help, and that is my main discussion. The second one is delay in reaching help, and then the third one, delay in the commencement of help when the person has already reached help. To just briefly explain what they mean here. Delay in deciding to seek help is, a woman, for example, having a case of an emergency, maybe she's in labor, or maybe she's just pregnant and any of the complications of pregnancy have come before her, maybe she's bleeding. And then to take that decision to carry herself and go to the hospital, the time between when the problem has started and when the decision is made to go for care is the delay in deciding to seek help. Delay in reaching help is all the processes between when she has decided and when she gets there, the transportation issues, the mountainous areas where they may be living, the bad roads, the no money for transport, the no bus passing here today, all the plenty issues that could delay her movement to get to the hospital. Then the final delay, the delay in commencement of help. She's already at the hospital, but then maybe queue up here, go get card, or have you paid for this? Or the doctor is coming, the midwife is coming, all the delays that may happen before the help commences. This is the third delay. And these 3 put together contribute so much to maternal death. But the first delay is particularly our concern in today's presentation. The delay in deciding to seek help. In our part of the world, it strongly borders around the woman getting approval, especially in northern Nigeria, where maternal mortality is even higher. But make no mistake about it, it is still very high in other parts of the country. So a woman is at home. From the things we see, a woman comes to the labor ward with a complication that probably started the previous day or hours before her arrival. And you ask her, why is she coming so late? And she says, my husband is not around, or my husband traveled, or I was waiting for my husband to come back to bring me here. So we discovered that this husband giving approval for something that is an emergency, he is not around, or even if he's around, he wants to decide whether they are going to get help or not, is a very big issue when it comes to women who are pregnant and who may be having one complication or the other. Even women who do not have complications should be able to take a decision to say, I want to go for checkup, I want to go for my antenatal, I want to go for this and that. It shouldn't even be when there's a complication already. But unfortunately, the ones we complain about most times is when complications come and we notice that there was a delay in deciding to seek help. And then you hear, couldn't get my husband on phone, or my husband traveled. There was a time I asked a particular woman, is it that husbands have this meeting that before labor, they all travel? Because in a particular day in the labor ward, we received the complaint of about 5 husbands traveling at the time their wives were in labor. So this concerns us so much, why men allow their wives to go through this whole stress alone, with all this kind of complications. So, for example, you are bleeding, blood is pouring, you can see it, but that decision. Sometimes when they can decide where is the money, they still have to wait for the husband to send money or to bring the money or to, somehow make the resources available. So that empowerment Dr. Peji was also talking about, how many women can afford to take decisions based on what is in their pocket. Okay, so one very funny thing I also noticed is that a woman will deliver in the hospital and carry her baby with an umbrella, and she's standing by the road and trying to flag down the taxi to take her home. These are terrible things that no matter how poor a family is, on the day your wife is having a baby, you should be able to get a taxi that will come pick her from the hospital and drop her right at home when she's done delivering. So these concerns are pushing us to campaign against some of these things, and I want to share them today. So, breaking the bias. So, an increasing maternal mortality in a nation, it means that the nation is dying because women die, leaving children that the man cannot care enough for. Some men have more than one wife, some have up to 4, and do not actually know all their children. So, imagine if 1 or 2 wives die from maternal mortality or any of the causes of maternal mortality. What becomes of those children? So when women continue to die like this, we will have a lot of people that don't get good training, which should start from home, through school, and what have you. And then things like the insurgency we see may never end in a society where every woman going into labor does not have 100% chance, or even near 100% chance of surviving the process, which is supposed to be a joyful process at the end of it. So breaking the bias here means that a woman must think safety first before you decide to. I'm talking about, for example, those who are married, because we know that some people who are not married can be pregnant and should be cared for as well. But for example, those who are married, before you start having your babies, the husband and wife are supposed to sit down and talk about this whole journey of the pregnancy. I'm happy with what is happening in some hospitals now, that they make it compulsory for some certain periods of the antenatal care. The men are brought and kept in the class and are lectured, and that is very, very good, so that they will know that they should. It's not even just about the whole pregnancy and delivery period, even participating in the life of the baby, okay? Because there's something we call postpartum blues, even postpartum psychosis. These things are, apart from the predisposing factors that may be there in some women, these things are majorly caused by lack of social support from home, and from people around, so that a woman is made to suffer a particular pregnancy, labor, delivery, and in the immediate post-delivery period, suffering with the baby without much social support. Some women who are prone to this postpartum blues and postpartum psychosis can't go into this, and some go as far as harming their baby, and it's not because they intended to, it's because it has become a mental issue for them. So men have to sit down with their wives to discuss, what do we do? How do we handle this whole pregnancy thing? Okay, so that every pregnancy is planned to carry it from the beginning till the end. Okay, so, and also to work together, and it's like no pregnancy is the same with the previous one or with the one to come. Every pregnancy is different. If you had it smooth in your previous pregnancy, the man shouldn't run off in the second one to say, everything was fine with the previous pregnancy, she can deal with it. No two pregnancies are the same. You could see somebody who did not have some certain bleeding or hypertension in pregnancy or convulsion in her pregnancy, in her first pregnancy, where it is commoner. They may have it in the second or in the third, because if they get into their 30s, there are more chances for complications. And this is even when men should even be more serious in taking care of their wives. Okay. Now, registering early for antenatal care. This is very, very important. One thing I don't want to forget about, Dr. Peju talked about the women, some women who prefer to see men. One thing I've noticed also is that even amongst us healthcare providers, we should take note of that. Women sometimes tend to be more hostile to women in labor. Women healthcare providers, doctors and nurses, tend to be more hostile to their patients, especially in public health facilities, because if something happens in private facilities, it's easy to sack whoever is not behaving according to the proprietor's way of thinking. In most of our public health facilities, unfortunately, even including the one I work with, you could see female healthcare providers being more hostile, sometimes even slapping the woman in labor, unfortunately. So sometimes if a woman says, I would prefer the man, check it. It might be her second or third pregnancy. Like, maybe she knew what she saw in the previous one. So I want to now speak to our female healthcare providers, nurses, midwives, doctors. The fact that you've had children yourself, because some women would say, are you the first person to have children? Do you know how many children I have and all that? The fact that you've had yours does not mean that this person is having life so sweet in this. Labor pain is terrible. It's very, when Dr. Peju talked about some faculties saying they don't want women, they can't stand for up to 5 hours in surgery, and then she compared it with labor pain, carrying the baby for 9 months. It is very true. Labor pain is more than any 9-hour surgery I've participated in. I would prefer the women continue to have it. I'm sorry, but we need to support them, and that's on the lighter note. We need to support them, and then women, let us also support ourselves. And I think that is what this month is about, and this International Women's Month and Day and Week and all that, so that women should know. Some people will say that the highest enemy of a woman is a woman. In some ways, you could see that it is true. We need to, but the fact that you've gone through it means that you should even put more care to it. You should even be more tender in handling these women. Okay, so please, let's advise our people, even ourselves, to register early for antenatal and follow it through. Even make friends with the midwives and people there, so that at the time the husband is not acting well, there is a midwife you could call that will tell you exactly what to do, or a doctor you could call that will tell you exactly what to do. Now, this is Nigeria. Things are not as formal as they are in other parts of the world. So please, if you have to make friends to be alive, please do. Now have a support system that is a bit larger than the immediate family. I've talked about making friends with the people in the hospital where you are doing antenatal. What about neighbors, people in the church, or people in the mosque? Let there be a support system, especially from mothers who have gone through what you are presently going through, before you. Let there be not the type that will deceive you and give you fake prescription. There should always be an expert prescription and advice to everything about you, what you're taking and what you're doing. But support systems that can come at the time of need to help you, maybe carry you or what have you, to even help with your mental stability, you need friends who know what is going on with your pregnancy. So I'm really particular about maternal mortality and this delays. So a few years ago, in 2017 or 2018, I did a show where I talked about the 3 delays in maternal mortality on our page. And at the end of it, I said, hopefully someday there might be an emergency number to call in this country. Now, I'm happy to announce that 2 weeks ago, there was the testing of this number in Abuja, and we received the road safety ambulances are involved, even the fire service people are involved, the VIO people are involved, and different hospital ambulances are involved, so that there are phone numbers given to these people that the 122 number can be diverted to, so that wherever you are, you have an emergency, you can call 112, not 122, 112, and you can get help. And there is a mandatory time limit within that help should arrive to you. If not, it is not an emergency call. So it was tested run in Abuja 2 weeks ago, and we saw how successful it was. So if your husband, for example, has traveled like the way they normally travel during pregnancy and labor, please, if you have an emergency with your pregnancy or with anything at all, even if you're not pregnant, you have an emergency, but you are not empowered financially, of which I'm sure the fight continues to empower women beyond here, okay? But just in case you're not empowered and you need that help, you can call 112, okay, if you are in Abuja. I don't know about other parts of the country. It's supposed to be a national thing. I'm sure it is still coming. Maybe they're starting with Abuja, but it is working in Abuja now, so that you can be picked up by any of the ambulances. They will reroute the number immediately, and then you will get help. Nobody should sit down. This is in first century. Nobody should sit down and die in silence. Just 2 days ago, a woman rushed her baby to the hospital. The baby drank kerosene, because the woman sells kerosene. And then probably neighbors advised her that to counter it, you have to give palm oil. Now, at this time, the baby is not that lucid anymore. So the palm oil just went direct into the lungs. The baby aspirated. And the husband came, breathing fire. because he said, I left a healthy child at home when I was leaving this morning. Unfortunately, the child did not make it. I can only imagine what might be going on between husband and wife in their homes now, you know. So most of the time too, when all the children are left for the wife to cater for without, you know, the husband always knowing what is going on with the children, things like this result, or vice versa. And that is why families should work together, you know, for all this to happen. So, and finally, I want to stress on maternal mortality, stress on preventing the 3 delays. I did not talk much about the 2nd and 3rd delay because most of them are not in our powers. The one that is in our powers is the 1st delay, and it mostly affects women. And most of the time, it is about decision to go and access care. And most of the time, again, it's about the husband has not approved, the husband has not given money, the husband is not around. If you're a husband, please stop this. If you're a wife, you need to look for an alternative way. When you save yourself first, then other things can be discussed. And because it is International Women's Week, I leave you with this, my message for the women. Thank you very much.
Thank you, Dr. Alex. That was a wonderful presentation. I was laughing just at the last bit of it, but the warning to the husband to stop traveling and stop, being unavailable. Thank you very much, and thank you for this very heartwarming message. To the women and ladies on the call, please have a good time just reading this heartwarming notes that Dr. Alex has left for us. I like the frontline perspective that you brought to the table, real life examples of how this bias exists, and the importance of a support system. For a society like ours that is not individualistic, this is one quick, low-hanging fruit mechanism that we can all easily adopt. It was also interesting that you highlighted the fact that bias also exists women to women in the healthcare space, and this is something that must be addressed. So we thank you once more for sharing, this very insightful, practical presentation on the ways that bias in healthcare exists and how we can address it. And I'd like to encourage everyone to please remember to drop your questions in the chat box. We will take them in the order and we'll receive them. For our final presentation, I am pleased to welcome a special member of the Healthcare Leadership Academy family, Dr. Benjamin Olowo-Jebutu. He's a graduate of the prestigious College of Medicine, University of Lagos. He's a detailed physician with postgraduate training in family medicine from the National Postgraduate Medical College of Nigeria, with special interest in maternal and child health. He's also an alumnus of the Healthcare Executive Leadership Program from the HLA. Dr. Benjamin is a skilled surgeon. I imagine that we have quite the emphasis on surgeons today, with over 12 years experience, who has worked successfully in several communities in West Africa. Under his foundation, Benjamin Olowo-Jebutu Foundation, over 2,000, and in fact, this number has increased in the last few months, free surgeries has been performed in states across Nigeria for folks suffering from fibroids, hernias, lipomas, and breast lumps. He's the executive director and lead surgeon of the Benjamin Olowo-Jebutu Foundation Love Team. He has very great communication skills and is passionate about improving access to quality health in Africa. Love and compassion is the core of his life and practice. Dr. Benjamin is a licensed member of the Medical and Dental Council of Nigeria, the Nigerian Medical Association, the Association of Rural Surgeons of Nigeria, an associate member of Nigeria Institute of Management. He's also the current alumni president, and this is why I said he's a special member of the HLA family. He's the current alumni president of the Healthcare Leadership Academy. Dr. Benjamin, it's a pleasure to have you join us this evening. The floor is yours. You're welcome.
Thank you very much for having me today, Elizabeth. And I want to say a very, very warm evening to everybody on the call. Thank you, Peju, for your very, very profound, thought-provoking lecture. And Dr. Alex, I celebrate you too. I will just share my screen briefly. Can you all see my screen?
Yes, we can, sir. Please go ahead.
Okay, good. So, break the bias, advancing women's health outcomes through bias-free health system. I love the way Peju talked about us making it very, very important and imperative on making women part of policy making in Africa, and especially in Nigeria. For example, when you have women that are ministers of health, they will understand, because they are now mothers and they are leaders, they can help change that sphere properly, because maternal health is a very, very big issue in Africa and in Nigeria specifically. So by a form of introduction now, I would say United Nations, in its question to endanger a level playing ground for both men and women across all human endeavors, resolved to give this agenda more voice this year. This is a strong position that women's space have been too male-dominated to the detriment of women. This notion has stated the theme of this year's International Women's Day, which is gender equality today for sustainable tomorrow. The theme of this year's celebration explains as follows: whether deliberate or unconscious bias makes it difficult for women to move ahead. And we all know what this means, because people are already biased about women in this, especially in the healthcare system in Africa and in Nigeria. You know, as Pedro said, the woman wants to see a doctor. A doctor feels comfortable examining a woman without getting a chaperone, because he thinks is the Lord over the woman. Those things are very, very important. And I think this month is a very special month for women. Gender equality is more of the 17th Sustainable Development Goal, designed to make global community a more productive planet, ending all discrimination against women and girls, and only about not only about basic human rights, but it's crucial for sustainable future. This paper hopes to address a bias-free health system that will lead to positive outcome for women's health. What is the concept of breaking the bias? The Oxford Language Dictionary defines bias as 1, inclination or prejudice for or against one person or group, especially in a way considered to be unfair. And 2, it causes to feel or show inclination or prejudice for or against someone or something. Biases are beliefs that are upheld without veritable facts about someone or something, particular group of individuals, especially women in Africa now. From the definition of bias, it is undeniable that there is sentiment, prejudice, discrimination, demarcation, unhealthy competition, impediment of talent and skills, etc. All these impediments are obviously against realizing the full potential of the human race. There are urgent needs to break. There's an urgent need to break this self-inflicted malady and break free to actualize our full potential as human beings. The true position of breaking this bias implies creating an environment in which people feel inspired, equipped, and supported, and which is free of bias, stereotypes, and discrimination. That is an environment that is diverse, equitable, and inclusive. It is a time to impute this fundamental notion in advancing the outcome of women's health in our health system. A health system where a person's gender doesn't determine the freedom they experience, the opportunity, their degree of safety, and the ability to exercise their basic human rights while accessing healthcare or working within an health facility. Bias-free health system for advancing women's health outcome. It is true that healthcare institutions are gender biased, and unfortunately, it is widespread, especially in developing countries like Nigeria. Patients, doctors, researchers, and administrators can all hold biased views about gender. These views affect how healthcare system works and have a serious impact on health outcomes. Gender bias means a preference for one gender over another. You can imagine how many researchers are with females in Nigeria, how many surgeons are females in Nigeria, how many doctors are females in Nigeria. So the system itself is biased to a lot of women in this country. This preference is often based on false beliefs or generalization that makes one gender seem better or worse than others. Across the globe, the most common form of bias against women in 2020, the United Nations Global Report found that close to 90% of all people have some form of gender bias against women. The following will necessarily this follows the brain bias that impedes the possible outcome of women's health. Education and awareness. It is important for healthcare professionals and the people that serve to understand that gender bias is that everyone that has these biases and how they affect healthcare. People and organizations can only stop reinforcing inequity by recognizing their biases and take actions to unlearn them. It's very important to take this very importantly because most of the top government policies, most of the people sitting there in spaces forming policies don't put into consideration women. When you talked about women as mothers, women as career people. Now, for example, now we had maternity leave for women, like in Lagos State. I see now men were also talking about having paternity leave instead of telling them to extend the maternity leave for women so that they can also fulfill their promise, they fulfill their role as mother to the children. You see a lot of women trying to breastfeed their children less than 2 months because they have to quickly go back to work and fulfill their career path. And now men say that okay, they want paternity. I don't like the idea because why does the man want paternity leave? Is he going to breastfeed the child? No. But we will have extended the maternity leave for women so they can have adequate time to take care of their babies, born with their children, and be happy with their family. Sex and gender diversity in research. Women now make up around half of the participants in clinical research, supported by the National Institute of Health, NIH. However, this does not cover all studies, and it does not account for decades of research that only involve males. Like Elizabeth mentioned, most times all the sampling, the core studies for these researchers are male dominated, and it's very, very, very it's not very, very right. And we have to speak against it and speak towards it in this new month. Health organizations and researchers must commit to sex and gender diversity in relevant studies and fund research to fill in the gaps in knowledge. Accountability. It is crucial that workplaces hold people accountable for any form of bias. This reduces the likelihood of harassment and bullying. It's also essential for healthcare institutions to become accountable for the ways that their policies, systems, and practice uphold gender bias. You can imagine what has happened in the Nollywood industry. You hear people say that some ladies have to go out with some directors or go out with some producers to be able to get roles on the film or on the project, but nobody talks about the males that they want making passes towards them. Is all about the female making the mistakes. Some says why the female is wearing this kind of clothes, and I tell them why are you looking at those kind of clothes to yourself? Because it's important we balance and we are accountable. That in our mind we don't feel that the women are weaker vessels, but we have to support them as original human beings that have their own individual inclination about productivity in this system. Equitable treatment guidelines. Quite a number of studies have found gender-based variation in how doctors diagnose and treat patients. Some found that doctors ask women fewer questions about their symptoms or prescribe women less the medication. Having standardized, equitable, and evidence-based rule of treatment may reduce this risk of implicit bias affecting healthcare. Until recently, that a lot of males are now making it very important to have chaperone in their consulting room when they're checking women. People just believe that a woman just lie on the bed, let me check you. The cordiality and the sensibility of honoring and giving honor to the woman is not there. So it's important that there's equity as doctors, as male physicians. It's important for us to support women and make them feel very, very dignified in this very, very important International Women's Day celebration. Equitable workplace policies. Similarly, clear policies about how institutions should address systemic inequity are essential. I'm very, very glad that we have four top banks in Nigeria being run by women, and you can see how they're doing. if you check them on the stock exchange, what they've done in the last few months, Fidelity Bank, GT Bank, and what they've done in the last few months when the women have handled it, is better than what women will handle it. So why don't we give these women equitable workspace policy that makes them become great in their minds? I don't keep them as just making babies and just making the home alone, because women are very, very great people, and I admire, I celebrate all the women on this platform. I know you will make this country great again. It may also include policies that support women who are new parents or caregivers. In addition, standard procedures for how organizations should respond to gender discrimination, harassment, and abuse are very, very crucial. Now, I can imagine somebody says that because a patient is HIV positive, he cannot work in an institution because it's not itchy. And I'm wondering why those policies are taken, because no, the person working in the place doesn't have to infect anybody, because it's not a hospital. It's not a place that just directly goes to also infect anybody. So those policies must give a very, very baseline standards for us to be able to affect and improve gender bias in Africa and Nigeria. Self-advocacy. So if a person believes that they're receiving adequate care due to gender bias, and they have to try a few things, seek a second opinion, talk to people about it, from other doctors, seeking specialists about what you're thinking, get doctors' recommendation from others who have faced similar situation, ask questions, don't feel bad, don't feel very, very timid in your ideas, go all out, be open to discuss about what you're going through. There are also ways to advocate for oneself. People can bring an ally to an appointment to support, to act as a witness. That's why I always tell people, a lot of men will tell their women, go, you are the one causing fertility, you are the one making us have children. And I tell them it's very, very wrong. The woman cannot make a baby alone. You have to support the woman. So for me, I see women, and if you have a fertility issue, I see the men and the women together. So it's a process. You have to form a bond. So it's not saying the woman is a problem, but you have to come as a family, because only a family can make a baby. That's why a doctor is not pursuing test or treatment. Ask the doctor to memorize that decision and their reasons for why, report biases or discrimination so that is obvious, and severe reports. If you don't feel comfortable, report to your senior colleague, as the case may be. This is my conclusion as I end this important. Gender bias in healthcare is a critical, well-documented problem that endangers people's lives and well-being. It is a component of sexism, which is a major cause of inequity worldwide, including health inequity. Gender bias affects diagnosis, treatment, and health outcomes, reducing the quality and effectiveness of healthcare. In order to stop this, organizations and institutions need to commit to changing their policies and their practices. I want to celebrate HLA for doing great work on giving women access to healthcare, giving women access to leadership, and giving women access to platform. At least over 50% of people working in HLA are women, and I celebrate what you're doing, and I appreciate you for bringing me on today again. Thank you very much for listening to me, and God bless you.
Well done. Thank you so much, Dr. Benjamin. This has been a very insightful presentation. I like that, you give it a very rounded viewpoint, just addressing all the various building blocks that contribute to gender bias in healthcare. And, right from the policy standpoint, even to, the frontline standpoint, it's important for us to see what's causing this and then address them. And I like the last point you made about the need for both organizations and individuals to commit to changing. There's a need for collaborative efforts for us to actually change the narrative and strengthen our health systems to provide care that is free of bias. This has been a very power-packed symposium. Dr. Kweju has done a great job engaging the comment section. Thank you, Dr. Kweju. In fact, I think that all that is missing in this session is just maybe a physical building and a sound system, microphone and lights. Everything else has just been perfect, and very important for the conversation going forward. I want to say thank you so much to our esteemed panelists. I like to imagine that right now our question bank is already overflowing, so that we can, because we have a short time on the call, I want to see how many questions we can quickly take. So I'll get to it before we round up this session. Favor, thank you for your contributions. Thank you so much, Kweju, for all that you have shared as well. Foster CJ, thank you so much for your contribution. I would like to just sort of resonating across the different viewpoints that was shared from our panelists has been around because we highlighted what the issues are and want to address, how to make it better. So I'm thinking, we already know who the actors we need to speak to, we need to involve, but what are the coordinated actions, across our very multi-layered health system that need to be taken and monitored for effectiveness, of these building blocks? Because it's one thing to highlight what the problem is, highlight what can be done, but there is the need for monitoring, for effective monitoring. And I'd like to start from Dr. Alex. So Dr. Alex, would you like to please jump on this question briefly? Dr. Alex still, I think he might be on mute, but while we're waiting for him, Dr. Benjamin, would you like to please address that question?
Okay, so you spoke about who is accountable, who monitors this thing. I think all of us should monitor it. So I like the way Kweju talks about it, about a woman from the point of being a career woman and also be a point of a so giving women access to that leadership role and deliberately creating that Ministry of Women Affairs that we have in Nigeria is just there for just story. They're not involved in making policies that really affect women. Somebody talks about women 35% plan in making women in leadership role in the Senate and stuff like that. And even the women themselves are not as knowledgeable as you can see the passion in which they talk. How many women can be able to conceptualize what is beneficial to them and not succumb to what a man is telling them to say? And that's the point for me. You must be able to stand up with your own concept, your own ideas, and have departments or people in Ministry of Health, Ministry of Women Affairs, coordinating women health. So you have somebody that is running the policies, and somebody running the policy in Women Affairs, somebody in Ministry of Health is the one monitoring on a daily basis action plans and also reports. Those reports are very, very important, and we see the report. We see the reports that are used to make decisions at the time, as a real time, because most times our decisions in Nigeria, especially in Africa, is usually 10 years back, because people have done these things like 10 years ago, and we're just thinking about it now. It's because there's no real-time decision and people are not proactive about it. So for me personally, I think the Ministry of Women Affairs should collaborate. Ministry of Health, Ministry of Women Affairs drives the policies. Ministry of Health will monitor the policies and make sure it gets to a very, very important end in Nigeria for now. Thank you.
Thank you, Dr. Ben. I see like 3 takeaway points already from your answer. The importance for cross-sectoral, collaborations, what really we should be doing in the women's ministry, what really, the pathways for collaboration across ministries, and the importance of data, to monitor where we are, where we need to get to, and what we need to do to get there. So thank you very much for that answer. Dr. Kweju, this question is, in fact, before I speak to Dr. Kweju, I want to applaud Dr. Alex and Dr. Ben for, being very gender conscious in their presentations, in the way that they kept alluding to viewpoints from Dr. Kweju's presentation. I think that this is very important for the way forward, the role of male allies in actually amplifying the voices, of the women folk, of the women's perspective in policy making and decision making. I think this cannot be overemphasized. So thank you very much, Dr. Alex and Dr. Ben. Dr. Kweju, you spoke very you emphasized over and over about how effective domestic partners women are and the need to empower them, for achieving any of our national healthcare agendas. What are the simple two takeaway points or simple practical steps that we can all in our various spaces, in our public, whether in our hospitals or in the public health sphere or in the front line or in the home front? What are the simple practical steps that we can take, each person can take in empowering, to help us achieve and empowering women?
Okay, so I'm going to try. And first of all, yes, you're right. I do recognize and appreciate the support that my male allies are giving me, even in this conversation.
Exactly.
We managed to make it a conversation about women, and they actually gave me the grace that since we're talking about women, they defer to the woman in the room because she's the subject matter and can speak the best of the subject matter.
Yes, you are. Yes,
it's not something that happens a lot.
No, it's not. It's not.
Mm-hmm. So yes, we do recognize. I just want to also support my male allies in saying that everything is measurable, and the ways we measure is specific. For instance, how do we measure? As an individual, first of all, women, I feel my own contribution is to get into spaces that they told me I didn't belong in and make my voice as loud as possible. That one I owe to myself, and I owe to the women that have come before me and the women that have come after me. The women have come before me who necessarily didn't see it as something they could do. So I say it on behalf of my ancestors, and I say it on behalf of my children. So I owe that to myself. And then second of all, can we measure? Measurement is easy. Again, when we break it down to methodology. In the clinical space, for instance, we have residencies, or we have surgeries. We can look at what percentage of the applicants to this residency are female, especially the ones that are male dominated. We can put in laws to say we want a certain level of female applicants. So if I say, for instance, the places in which we say we don't see enough women, we can say we are expecting 60% application of the 100% we are expecting, we want at least a quota of 40%. So that when we get to 60%, if we're looking for 100 candidates, when we have 60 men, we stop. And before anyone says it's unfair, it is fair. The only person that is saying is unfair is the person that does not recognize or maybe does not know the gap already of how many people. Go and look at how many women are being sent to school in the first place. Not because you live in an urban city. Look at how many women nationally are not being sent to school in the first place. Before you can say, oh, if I ask for 60% or if I ask for 40% application, that must be from a female applicant. But you weigh that. Everyone likes to look at their own narrow space and say this is not fair. But women are coming from very terrible numbers of bias and discrimination. So it's going to take a concerted, deliberate effort to reverse that. So in the clinical space, in the healthcare workforce space, we want, for instance, we can say we want a certain minimum level that should be occupied by female applicants. And then we measure after 3 years, after 5 years, how many of the women that got into those spaces remain in those spaces? How many of those women had gone to the top? How many of those women had a child? How much time did we give to those women to be able to give birth? Because we always said that, when women take time to give birth, they stay away from work. If you ask, the concept of working from home was proposed by women several years ago to say, can I work from home and have my baby? They said, no, it's impossible to work from home. Then COVID happened and the men were affected. All of a sudden, we're scrambling around.
We are all working from home.
We designed a system to work remotely. when it was not about, when it wasn't women asking for that system. So you see, it's not, the system can be, it's not that, the system cannot be responsive. It's just they don't think the person that is asking it deserves that response. The whole world sat down and worked from home. We continue to send rockets into space from our homes. It just was that we didn't like the people that were saying they wanted that time. So we, you know, I said that specific, every system, we should specifically ask for measures, reduce entry barriers to gender, be deliberate about the quota. In Nigeria, we're deliberate about other kinds of quota, tribal quota, and it's not ridiculous. We have no problems with saying that the presidency should come from here, 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 here. But propose that a woman, 50% of this seat should belong to a woman. Oh, that's so ridiculous. What's ridiculous about it?
Can I have my voice?
There are universities I can't get into because I'm not an indigenous, and that is in the law. But tell them to apply it to my gender. And all of a sudden you see people throw their hands up. Oh no, we can't do that. Is this the most ridiculous thing you've heard? I bet you not. So I'm going to let Dr. Benjamin respond to me.
Let me add my voice what you have said today, because I just came back from Castina and Bauchi, where we had surgeries for people, and there were more women, and I was asking questions, women that they're just at home making babies, and I asked them, how many children have you got? How many children have you got? They said they are number 17 child, and the husband wants them to do 40 children. And I'm asking why? And I'm asking them, why do you think? And I said, no, is what Baba said that I must follow. What could you have said is very, very critical. And I think we must vibrate this thought, and we must escalate it. That if there are policies that helps men, so to say, not do family planning, or you now give policies that make women do family planning. So you see a woman but a man can, but the man just comes at home, come back from work, and pumps the woman and makes baby and has four wives and has 40 children and makes the woman fit for them. So it tells you, I give them 500 naira every week for their children. And I'm wondering, why are these policies always against women? Are the women are they not speaking up, or we just believe that they are weaker vessels, their voice must not be heard? No. So we men now must consciously begin to speak for these women, because when you make a woman great, you make a nation great, because all of us came from the women. They are more sensible, they are more powerful, they are more humane, they have more feelings. A woman will not steal 1 billion and take her eyes off it. But a man will steal that money and not wait because he doesn't even care. So we must deliberately support women, creating policies. For example, as I said, if you say you want female surgeons in Nigeria, you can say anybody that applies to LASUT or to LUTH, if you're a woman and you are less than 30, you get a space automatically, because we want to encourage more female surgeons, so that those female surgeons can also mentor young female, that they can become surgeons too. The point is that we have very few mentors that are in that space, because we are not creating anybody to be mentors. For example, you see a girl that says she wants to be a big boy, like Wizkid, like Davido, because the people they are seeing in that space are those people. They are not seeing female mentors that are doing great stuff. The Larry Clintons, the Obi Sekwesili. So it's important as men. I'm very, very deliberate about it. I celebrate women passionately. I treat women very, very passionately. I support what they're doing. What Pedro is saying is very, very important. That's why I said to myself, men were saying that people cannot work from home back in the days. Now, COVID has started. They are the ones staying at home, taking their coffee, taking their beer, and still working from home. But back in the day, they will say a woman should not take should not take off. You do a surgery for a woman that has fibroid surgery, they'll tell you that your guy is a male HRO. He says she must not take more than 3 weeks off work because they'll take her salary. And I'm wondering, if you are in her shoes and you have a fractured knee, are you going to tell them that you can just take 3 weeks away from work? You must deliberately put policies that supports women to grow and make them happy and relevant in this system. Thank you very much.
Thank you, Dr. Ben, and Dr. Kweju, thank you very much for the points you highlighted, around the role every individual has to play, deliberately get into spaces and amplify your voice, in places where, typically it's not the norm to go there. And thank you, Dr. Ben, for what you mentioned about mentorship. I think mentorship cannot be emphasized, the importance of it in advancing outcomes for gender parity and women in healthcare leadership. I have one final question before we round up this conversation, because we've far spent our time. And this question sort of speaks to, because we've spoken about, how access to care can be impacted by, finances, by, and also protecting, financial risk for accessing care. What are the ways, or what can be done about the design of our health financing policies? Yes, and this is peculiar to Dr. Kweju, because she's walked around, the universal health coverage space as well. What are the what can be done? What are the steps that can be taken around the design and implementation of context-specific, health financing policies that will further help to
absolutely
advance these healthcare outcomes for women?
Oh, yeah, I'm so happy to take this question, because we need women to have money that's their own and they can make decisions about. Not just because they are individual patients, but because they're also caregivers. So how do women have money that is their own? Again, at the point of entry, the way we design these things, very patriarchal system that we don't even recognize. How do women even get identity cards that they are of their own? When to get a passport, they ask me if I am married to get from my husband. If I am filling a form to open a bank account, right? A lot of these soft loans or these access collect data on the woman's identity and ask already that she would put in the identity of her husband. Or a lot of women fill a lot of these forms thinking, oh, okay, which space is this for my husband? And that is because already, think about all the levels, we don't have women that go to school on their own. So do we have bank opening or account opening modalities that are available for women who necessarily cannot read and write? Which is, to an extent, that thumbprint. Because the thumbprint thing that is done in some of the urban areas that I have gone to, in this Africa, in this Lagos, when we collect data from a woman, are we able to sit her down and collect all the data she needs, that we need from her, and she doesn't need to involve anybody else in that process? Our processes are not designed to look at the person that has not been through school, even when we have the data that most of our women are not in school. Again, we use literacy. We cut off a lot of women from the ability, from many processes that are designed around people who can read and write. We are cutting off a large percentage of our population, which are female, and we're not responding to it. I think one of the best things that can happen is the ATMs that have a thumbprint. But when they have a thumbprint, they should go to voice, because when you put the thumbprint, that's a good step. You go right back to reading. And then she turns around to somebody on the queue to say, come and help me. And then you what's the word? You emphasize that sense that she cannot be fully autonomous over her own money. And I speak about it on this level because even when we say we want to sell insurance, linking it to the data we have collected, she's still reliant on either her husband or her son that she has sent to school, or that neighbor that went to school, because remember, she didn't go.
Yes.
So we must design these programs, even data collection, even data, and we must design everything with autonomy for the person that we cut off in the first place. I was discussing with someone in the chat box about even systems that are coming from the Western system. The Western system, it's full of liberalism, but it's also full of patriarchy. If we look at the family planning messaging, oh, get it together as a family. When you go and look at the family planning, you see a man and a woman and a child. That's good, but what it does is that it makes a woman who is unmarried feel like I cannot approach the family planning to plan my reproduction. I cannot decide to abort the baby I don't want. Because already there's that system that says, go and bring your husband. You want to put square. Have you discussed it? Have you bring your husband? What does your husband have to say? I can't do it all because I know the problem I face. And it's true, some health workers will, they are the threat to their lives, or because they are not able to perform reproductive autonomy on somebody's body in front, one is standing in front of you, well over 18, and nobody is allowing that person to be able to say, I don't want any more children. Somehow it's not her decision, even though she's the one that could enter the maternal mortality pool. She's the one that at the same time will not be able to decide when to have a CS. She's the one that they will not allow to work from home. She's the one that cannot breastfeed for 2 years. And yet when the child falls ill, she's the one that takes the child to the healthcare center. Because at the healthcare center, we give men paternity leave, but are we recording the number of healthcare center visits or child wellness visits where the person that brought the person is the father? That's when we know we're serious. I don't mind paternity leave, but it's not for the men to sit at home. If I want paternity leave, that means I'm collecting data. The men I sat down at my ANC education, I want to see them bringing the children for immunization. I want the men to know the birth. There was this viral thing on social media where we thought it was funny that men didn't actually adequately remember the birth dates of their children. It's what we allow that. We allowed it.
Sure.
So everything can be measured, and there's no catch-all way to measure. But for me, in our own system, if we deliberately realize we've cut off autonomy from women by not sending them to school, then the systems we built must be deliberately responsive to that population that we cut off. Until then, I don't think we are serious.
Thank you, Dr. Kweju, for this very insightful response about, how far we need to go and what we need to do to get there. Dr. Alex, I don't know if you're still on this call. I'd like to give you, 2 minutes to just share your final thoughts on, what we can do to further advance this conversation.
Okay, thank you very much, and thank you everybody for the contributions so far. My final thoughts: we need to carry this to what I would like to call a popular thing, train the trainers. I saw a nursery school book where the teachers were teaching the children the roles of the parents, and when they explained the role of the mother, everything was about the domestic things in the house. Now, this is taught to a whole class of boys and girls, and then they carry it. And I'm sure there are other ways they are being taught in the primary, in the secondary, even in the tertiary institutions, that kind of segregate these roles to say a woman is supposed to be this and do this. The man is supposed to be the other and do the other. Now, this kind of campaign needs to be carried to the level of knowing what content our teachers, the teachers that teach our children, what do they have? Because we keep on pushing. We may not reach the level we want to reach within 1 year, 2 years, but by the time those children who are in nursery school today are graduating from high institution in some years' time, there's supposed to be a total turnaround of this whole thing by then, if we do the right thing at the stage where they are. So that people are educated from now on rules and why things should be the way they should be. And one final point, talking about policy and why I support that policies have to be made about women in things. For example, common entrance score for people going into secondary schools are not the same. The cutoff marks are not the same across the country. And it is because they are trying to bring up educationally disadvantaged states to get more of them into schools. That is beautiful, if you ask me.
And then so that those that, you know, are doing well in academics always know how they will get around it because they are sharp. Let them have more competition and do better. Fine. So the same thing has to be done for women. And this argument needs to be brought to challenge it. Women are not getting what they're supposed to get. You know, you can't say, let them rise up and fight for it. Let them go and contest the way others are contesting. You know, if you contest, even women will tend to vote for men. But like somebody said, if this number of men are already into this program, let it stop at that point, okay? Let the remaining slot be for women, whether they get 2 votes or 3 votes, you know, way less than what the men are getting. Let this space be for them so that everybody will be brought up eventually to the same level. If we continue to say, I did not stop any woman from contesting, or I did not stop any woman from becoming CMD, or I did not stop any woman from this research or that research, it cannot work because it will seem as if this gender is fighting this gender. And it shouldn't be about fight. There are countries that have exceeded what we are dreaming of here, where women are doing things. Okay, look at countries that are being led by women, for example. But here we still look at women like that. And then traditionally, our cultural senses need to start changing, where even a mother will be telling her daughter, you are a wife, you are a woman, you are not supposed to do this, you're not supposed to say that. You know, continuing generationally, a culture of subjecting women to mediocre roles, you know, to tell them you can't aspire beyond this. You know, even mothers do that without knowing, out of love for their children, if you ask me, but they do the wrong thing. So we need, even at the traditional level, to liberate our women from, like, if you like, shackles of this being relegated to one side that they cannot aspire. We see those that aspire, it will seem as if it is a rebellion, you know, and eventually when they break the roof, you say, wow, you know, but initially it usually seems like a rebellion, okay? But let us make it something happy, so that if a woman strives that she is doing this, I'm doing residency in neurosurgery or in orthopedic surgery, or I'm studying this aeronautical engineering, it won't be out of, I've disobeyed everybody in my village to do this. Everybody will not do it happily. And she won't come out and be like, the man said I cannot do it. I've done it. It will just be like a normal thing, seamless.
True,
you know, I support less fight, even from the traditional level, especially with our mothers. Like, I want to repeat again that sometimes women are the main enemies of women. A lot of men advocate for them, and you see some women saying, that one, you won't win, you're not going to win, you're not going to win. You know, thank you very much, please, HLA, for this.
Thank you, Dr. Alex. Thank you for further emphasizing the very salient role that culture and conditioning plays in this conversation. And I like also what you mentioned about inclusion. Inclusion is you know, we can't overemphasize it. Inclusion is very important for us to keep this conversation going for. Thank you, Foster, Favor, you know, for your contributions. And I'm really thankful to everyone who's joined this session and who was engaged. We hope that everyone leaves this session with a renewed sense of commitment to learning and exploring new ways that they can advance, you know, both leadership, as well as, you know, amplifying gender parity in ways that you know, impact women's access to care, and just, you know, the healthcare outcomes as a whole. Because, like we've reiterated over and over again, there's, you know, from barriers, reducing the barriers to entry, to, you know, even the ways that women healthcare providers respond to other women, and vice versa, the way female patients respond to women healthcare providers, you know. So it's quite a mix and interwoven, you know, it's a web of so many elements. But, you know, we are hopeful that, you know, with the mechanisms at our disposal and with the emphasis on policy, you know, just changing the narrative of our policy to include the people, you know, who are primarily affected by these policies. So thank you once again to our esteemed panelists, Dr. Kweju, Dr. Ben, Dr. Alex. We can't thank you enough for your invaluable contributions. I want to thank our audience for joining us. It's been a very remarkable, long time of learning. I'm sorry that we extended the time, but we'd like to encourage everyone to keep the conversations going on social media, in your offices, in your hospitals. You know, just keep these conversations going, because one good act, when multiplied by several others, you know, can change the world. So if you have further questions, please engage with us via social media, and we'll be happy to continue. Thank you once more for joining us today. Please join us at our next webinar. Have a wonderful evening, everyone. Thank you.
Bye.
Goodbye. Thank you.
Bye.
Thank you very much.
Thank you. Bye.
Thank you. God bless.